So this is a 49-year-old with lung cancer and oligometastatic disease. And as I said, oligometastatic disease has different definitions from different hospitals. Here at Hopkins, we go by 5 metastases to call something oligometastatic in our patient population. So this patient had significant pain. As you can see, VAS of 10 on 10, was on escalating dose of narcotic analgesia, and almost was living in his recliner both day in and sleeping in his recliner. So significant pain. This is his MRI that you can see, and this is the T1 without contrast, and you can see the involvement of the L3 vertebral body. This is the stir image. Post-contrast is enhancing, and you get a good idea about it's almost involving the whole vertebral body, and you can see the paraspinal component also of this mass. So I would be really interested in knowing how people would approach this, how they would treat. And but as we are going through that exercise, I would say what we did. So we have our spine tumor board, multidisciplinary, and we started out with an idea of ablating this, doing a cementation, and follow it up with SBRT, just based on the significant mechanical pain that the patient had at the time of presentation. So that's what we did. We ablated the vertebra, and then we put cement in nicely, and you can see the cement was completely within the vertebral body. There was no extrav. And this is, so we follow this, the patient had significant pain relief, almost a VAS of 2/10, which was continuous for next 4 or 5 months. And it was, the patient felt so better that he actually refused to go for radiation post-treatment. So this is, we followed the patient with CTs and all that, but this is a post MRI scan that we did about a year later. And you can see the treated level is showing some enhancement along the inferior aspect. Patient has developed a new metastasis in the L4. But this is what I wanted you to get an idea about. So this is the ablation zone after we did our ablation, and of course there is cement inside it. And even the soft tissue component has significantly reduced in size from where it was before. I will be talking about perfusion imaging, but just to give you an idea, we're trying to do this on most of our patients now, and we are doing an early, this is a dynamic scan that we do. It's an early arterial phase, mid arteriovenous phase, and this is a delayed phase. So whatever enhances early on in the arterial phase is always sinister. And you can see the new metastasis is enhancing quite a bit, but we really do not see any enhancement in the treated vertebra. So there was, and as I said, the patient did very well, and he's continuing to do so. So just to give you an idea about pre and post ablation and cementation, what it looked like, and our ablation zone was pretty good in this patient. He's a mechanic, and he's able to carry out his routine activities now, and the pain is still also, we're still following him, and it significantly is bearable. Actually, I'm doing some facet blocks on this patient. So overall, if we talk about the osseous metastatic disease, about 1.5 million patients develop cancer in this country, and 70% of these patients will develop osseous metastatic disease at some point during their disease process. And fortunately, only about 10% of these patients will present with significant pain or epidural disease or spinal cord compression that acute intervention need to be done. Vast majority of these patients are perhaps managed conservatively with analgesia. Overall, we know that spine is quite common. So why is spine so common as such? The catchment area is the biggest thing. It's the valveless venous system that has connections with the chest, abdomen, and pelvis, so the tumor cells can go freely in and out there. The tumor cells produce these cytokines that induce the osteoclastic activity, cause osteolysis within the bones, which in turn releases some growth factors. And we know especially 2 cancers such as breast and small cell lung cancer, which actually produce chemotactic tumor factors that attract the tumors to the bone. And of course, the prostate and breast can be osteoblastic also. So the things that we are seeing, of course, we all know who are active in spine oncology that the patients with stage 4 disease, which once you get osseous involvement patients are definitely living a lot longer than they used to 10 or 15 years ago because of the significant improvement in all the treatment modalities that's being offered to these patients. But it is coming at a cost, and we are seeing more and more patients with metastatic disease now. So when it comes to imaging metastatic spine disease, this is a classic patient with a lytic/blastic mixed density metastasis involving the L4 vertebra. You can see that it's extending out into the pedicle. On an MRI, you can see that there is a paraspinal mass. So really, if you have to treat this patient, be it radiation or be it surgery / interventional, you really don't need to biopsy this patient. This is straightforward. But obviously, most of the radiation oncologists especially will need biopsies, and that at times can be difficult for certain tumors. This is a patient we just had this week, and I just biopsied this patient 2 days ago, and it was referred from an outside hospital. MRI was contraindicated in this patient, so we just had to base everything off of the CT. And you can see the lytic destruction of the C2 vertebra. There is a soft tissue mass that is around this, and you can see that the cord has been compressed to one side, and this is the mass here. Here, really, we at Hopkins, we are a chordoma magnet, so we are always in the back of our mind. Chordoma is always in the differential, which should be in a case such as this. And unfortunately, we could not further characterize this with MRI, which would have been very helpful, especially when it comes to chordomas. So we had to biopsy this just to exclude chordoma in this. So we do the biopsy planning and all that. FNA is okay, you can do an FNA, but you really hate yourself that why did you even get in there when the pathologist tells you, no, I really want a core, I can't tell you anything on the FNA. So we ended up coring it, and as I said, this was just done 2 days ago. The prelim is leaning towards a chordoma in this patient. So yeah, most of the biopsies are easy. You can easily do them, but some of these biopsies are very tricky. So that's what prompted us to really think that, is there something in imaging that can be done which will further substantiate or further improve our conventional imaging techniques? Just to show you an example, this is another case that was referred from an outside hospital, history of neuroendocrine tumor. Patient was complaining of this low back pain going into the buttocks, and obviously on the conventional MR, you are seeing there's a mass within the canal and it's involving the bone also. So highly suspicious based on patient's clinical. This patient was biopsied at the outside hospital. This is what the biopsy results came out to be. So it's highly unlikely that this is reactive changes and nothing sinister. So obviously, we did not believe in this, and we did our advanced spine imaging protocol, in which we do the conventional part, and then we add a diffusion imaging, just like brain tumors we are doing diffusion imaging, and that has become such a pillar of evaluating brain tumors that you are now triaging the patients or even telling whether it's a grade 1 versus grade 4 based on what you are seeing on your diffusion and perfusion imaging. So we thought that we can extrapolate the same data and put it into the osseous spine also and see what it does. So it's still, I'll say that this is still a work in progress for us, but we are seeing some exceptional results with this. So, and I can't really go in this lecture about all the advanced imaging techniques and how it is done and all that, but just to give you an idea, this is an ADC value that we go by, and usually in the bone world, we are comfortable with an ADC value of 1500 and above, and anything less than 1500 makes me really nervous. and this was 960. So that is very, very ominous. So again, we did our perfusion imaging. As I said, that this is a dynamic scan that we do. So this is the non-contrasted portion of the study. This is the early arterial portion of the study, and this is the mid-arterial. So anything that enhances like a light bulb in the early arterial phase, yeah, it's always a red flag. So based on off of this, we knew that this is not going to be reactive changes or anything. This has to be tumor. Patient was taken for biopsy, and this was the biopsy result. So that gave us more confidence in what we are doing with these advanced imaging techniques.
Hey, Mike, can I interrupt you for a second?
Absolutely.
Because this is the next case. So I want to ask our co-hosts, how many of you use imaging like this at your centers? Anybody? Because we don't. And I don't know that very many places are as advanced as you are.
So we actually, this was started at Sloan Kettering. And we have been doing this for last 2.5 years here at Hopkins. And we are as I said, this is a work in progress. So we are doing this, but we are still biopsying our patients to make sure that our pre-imaging or the post-advanced imaging suspicion or the differential is correct when we get our biopsy results. And I would say that probably 7 out of 10 times or 8 out of 10 times we are proving to be right. And we're not doing it on every case. We're doing it when we are discussing this in our tumor board, and there is always a question of, hey, can this be this or this and this? So we're using this pre-biopsy, and then still right now we are biopsying it. But I think next 2 to 5 years, we would have gathered good data, and we would be definitely getting better as we are in the brain world with the brain tumors and all these parameters that we are using.
I agree, except that spine is much harder than brain, and we know the different histologies. Because the audience might not know perfusion is based on the vascularity of the tumor, so it'll be depending on your histology as well, right?
Absolutely, absolutely. It's histology of the tumor, how vascular the tumor is, and this case is actually going to show that. But let me add that the tumor that has been studied the most when it comes to diffusion imaging is chordomas. And everything we are extrapolating the numbers, benign versus malignant tumors in this realm, is really our benchmark is the chordoma numbers. And chordoma usually is, as I said, 14 to 1500-ish is above that you're fine, below that you start to get NC.
Hey, John Shin, do you use that at MGH? Oh, he's muted. There you go.
We do selectively, not that routinely though. So I think this is very interesting. I mean, I think that the situations where we use a lot of these different type of sequences is when we're really looking at like spinal vascular malformations. That's probably the most common situation. But for tumors, not. I'm very interested by this. This is really fascinating.
Yeah, it's like Dr. Khan said, it's been around a few years, but it was kind of stuck, I think, in Sloan Kettering because not many people can replicate the results. But it sounds like at Hopkins you're doing it, so that is very exciting.
Yeah.
Dr. Khan, I'd be
go ahead.
Hey, I'd like to ask you a question about the management of your first case.
Sure.
So, sounds like you and the tumor board decided to start with kyphoplasty and ablation. When does your group decide to start with that rather than start with radiation? And the second question would be, will you be going over some of the evidence behind ablation?
I definitely can, but I have not included that in my talk. I thought that I had only 20-25 minutes, but absolutely.
I made him take it out.
Interested, I can definitely give definitely put on references for ablations also. Absolutely. That was one thing when we started all of this, which was about I think 10 years ago. That was the question that was asked. Okay, what does the literature say? And I'm glad now that we have enough literature to back us up. There was a landmark study that was done in 2015 actually not a study, it was a consortium of at least 12 different hospitals in which neurosurgeons, orthopedic surgeons, rad-onc, neuro-IR guys, everybody was, and then they came up with a treatment paradigm of spinal osseous metastatic disease. And they broke up the osseous metastatic disease into 6 different presentations, from asymptomatic to patients with cord compression. And in almost all the group, vertebral augmentation and vertebral osseous ablation made to the paradigm of the treatment of these osseous metastatic disease. But I'll be definitely willing to share it. Hopefully I can email it to you, or if I'm given an opportunity next time, I can present that, the whole talk about ablations.
Great. And so when do you start with that rather than start with radiation?
So as I said, that patient was in severe pain, a VAS of 10 out of 10, and he was almost completely immobile. So radiation does help with pain. We all know that, but it takes a little bit of a time. So, and we said that he's in so much of pain that we will start off with ablation and cementation, and then the patient would go to SBRT. So here actually we have started a study on this also at Hopkins, that some of the patients we are doing ablation first followed by SBRT, and some we are doing the SBRT first followed by ablation. And so we will hopefully analyze our data because we want to see the long-term which group of patient is doing how. From a survival point of view. Okay, so anyone want to take this one? If not, I can just.
I think Coy should take it.
What's that?
If he wants it, Coy Tan should take it if he wants it.
Sure.
He said he's great at this.
So let me tell you. So this is your pre-contrast T1. This is your stir, and this is your post-con.
Lots of badness in the sacrum.
A lot of what?
Badness.
Oh man.
True. It is a lot of badness. But you can see low back pain, 6 months. VAS is not that bad. 5 out of 10. She did not have. She did not have any radiculopathy. So based off of these images, it's really, really bright on stir imaging. And when you see something that is so bright on stir imaging, you tend to think about vascular etiology. But I have seen plasmacytomas do this. I have seen myelomas do this. So you really cannot be 100% sure just based off of the conventional imaging that this is what it is. So we got our hands on her old scans from 2016, and you can see that it started off as a small lytic area in the bone and then progressed to 2018, but it wasn't like completely destructive lesion. You can still see some bone around this lesion. So, and to top it off, she extremely active person. She's a gym trainer, and I kid you not, Dan Schubert told me that she was actually doing push-ups in the clinic before he could come and talk to her. So very, very active person. So we really wanted to make sure that that what the diagnosis is, and as I said, she didn't have any radiculopathy, no leg weakness, only just a little bit of pain. So based on this, we were thinking about a vascular etiology. We were thinking about, as I said, plasmacytomas and myeloma here. This is too bright to be lymphoma. So the next logical step, we went in, I did the biopsy, and of course my whole syringe filled up with blood, and of course it came out to be non-diagnostic as was expected. We did our advanced imaging again on this, and here you can see, as I said, the ADC number, that is 1556. So obviously now I'm not really worried about any bad etiologies right here. In this case, we went a step further and we did a TRIX imaging, which is actually a cine map of this contrast when we inject. As I said, this is a dynamic contrast injection. So it gives you a dynamic imaging when you do a cine, and you can see how it fills up. That's classic for hemangioma. It fills up initially, and then later on in your dynamic scan, the whole thing fills up. And this is just the static images of the same. This is the early arterial phase, and this is the delayed phase. So there's really nothing else that you can put in this when you have something like this on your perfusion maps. And patient was taken to surgery, and that's exactly what it turned out to be, was a vascular malformation. Just to give you an idea, so this is the case that I just showed you, which turned out to be hemangioma. This is another case that we had, and you can see on this perfusion imaging, initially it just lights up as a light bulb, and then it kind of faded off a little bit. So we knew that this is going to be extremely vascular tumor based off of this. So we entertained the diagnosis of angiosarcoma or hemangioendothelioma / solitary fibrous tumor. And this turned out to be a solitary fibrous tumor when it was taken out. And this is just to give you an idea about the third thing, which we normally see, something that enhances so much and keeps on that enhancement. And this is typical of metastatic disease. So again, work in progress, but hopefully we'll improve further with this type of imaging. So with the traditional treatment options that are available to a patient with spinal metastatic disease, of course, pharmacology, hormonal therapy for breast and prostate, you have the narcotic analgesia, RT. Our radiation oncology colleagues are really the quarterbacks in this world. RT is very, very helpful, but it does take a little bit of time to achieve maximum benefits. SBRT is definitely much more improved compared to the conventional RT, but the Sloan Kettering data shows that there is a 40% incidence of developing compression fractures post-SBRT. Our own data from Hopkins, we have seen a 25% increased incidence of having post-SBRT compression fractures, and that's because we have decreased the dose and increased the fractions a bit. And of course, surgery is the mainstay of treatment when it comes to patients with spinal instability and high-grade cord compression, followed by radiation oncology as such. So we here go by the SIN scores in our tumor board. That's one of the things that we utilize. We utilize the Bilski grading system or the spinal cord compression grading, and of course the norm score, as I'm pretty sure most other universities do that. So these are the parameters that are used, of course, and total score of 18. And I just wanted to give an idea about how we triage our patients based on all these scores. And you know, SIN score is really good. SIN score is validated across the board. But there are instances where we know people who treat these patients know that although sometimes the SIN score is low, but the spine, based on how the patient looks and what the signs and symptoms are, you have to do surgery at a lower score, or sometimes you just can get away with doing red-onc treatment at a higher score. We know that. So it's how it is, but definitely has been validated for spine oncology treatment. So we use this in our hospital for the triaging, is that if you get a score of 0 to 6, it's a stable spine. Depending upon the pain score of the patient, this will go to either radiation oncology or it will come to neurointerventional radiology for treatment based on if there is presence or absence of any compression fractures and all. Obviously, a score of 13 to 18 is an unstable spine, and definitely there is no doubt that it is going to go to surgery, followed by radiation oncology, whether they want to do an SBRT / conventional RT. So where we fit in is this, the 7 to 12 zone that I have consistently seen that our radiation oncologists sometimes do not feel comfortable. They think that it's not stable enough for them to take. And of course, our neurosurgeons think that it is not unstable enough for them to take. And that's, I think, where interventional neuroradiology / spine interventionalist fits in the tumor paradigm. I mean, treatment paradigm, sorry. So this is what we try to use in our hospital as such. So if you look at this case now, so this is a metastatic bladder cancer. Again, a VAS score of 10 out of 10. If you go by Shin score on this patient, the Shin score comes out to be 9. It's a junctional zone, L1, so you'll give a score of 3. Patient has mechanical pain, so it will get a score of 3. This is a lytic bone lesion, so we'll get a score of 2. Alignment looks okay. There is really no collapse of the vertebral body, but definitely there is involvement of more than 50% of the vertebral body as such. So we'll get a score of 1 as such. And if you are a purist, there is some lateral involvement, paraspinal involvement, so you may give it a score of 1, or I just gave it no posterior lateral involvement, so gave it a score of 0. So total score came out to be 9. Patient was in significant pain. This was actually a patient that we were setting up to get SBRT, but he had so much pain that he could not even lay flat on the simulation CT that they have to do. Actually, we have had few patients who did exactly the same, that they could not even lay flat, and then they were transferred over to our side first for treatment. And this was one such patient. So in this patient, actually, I used the Kiva device. And after I ablated this, this is a peak that has holes on the inside only. So as you push the cement in, the cement stays within the device as such, and there is very less chance of cement extravasating on the outside of this device. I really love to use this device in patients with destruction of the posterior cortex, so that the cement stays where it is meant to stay. And as you can see on this fluoroscopic image, very nicely put cement filling up that hole. And this is the cement in that hole that was in the vertebral body. And this on axial image, you can see that there is absolutely no extrav, and the cement is very nicely sitting within that hole in the vertebra. We can use this device. We have curved balloons, we have straight balloons. So we have a lot of things that can be used in almost completely broken vertebral bodies now. And we are able to keep the cement where we actually want it to be. Patient with spinal osseous metastatic disease, you have all these options available for the patient, from surgery to rad-onc to med-onc. And as I said, now with radiology also coming in the mix. This is a question I get quite frequently whenever I present at national meetings, is that why not only cement? Why do you have to ablate also? Because when you put in the cement, and as the cement polymerizes, it does generate heat, and it goes up to about 50 to 60 degrees, 55 degrees centigrade. So it does cause some coagulative necrosis of the tumor cell as such. So, and this is what we used to do for years and years and years. We would go in pathological compressed fractures, and we would put cement in, and the patient from pain perspective did quite well. But then we realized over time that we're just helping out in the initial treatment of the pain, but most of the time the tumor spreads beyond this cement. So this is like 5 months later, the tumor has jumped on the back end of the cement, and then there is epidural extension right there. Multiple examples. This is another example where the patient did have retropulsion of the posterior cortex, as you can see here, did have impingement of the spinal canal. This patient refused surgery, so that's why, and had significant pain. And so one of my partners just put in cement into that vertebra, and this is like what, 419 and 619, 2 months later, more retropulsion of the posterior cortex, and of course the patient ended up having surgery and posterior decompression.
Hey,
This is actually.
Can I interrupt you for a second for a question? So one of the audience members asked, what do you do when there's a breach in the posterior cortex? Because I know it used to be that we didn't want to do cement augmentation in those cases, and increasingly we are.
Yes, so that
pushing the limits of that.
That used to be a contraindication for interventional perspective or interventional treatment. But as I said, with these devices coming in, which have quite good protective mechanisms, and especially the Kiva device and the curved balloons and all that, we are now venturing more and more into the vertebrae with destruction of almost all the walls. And I have a couple of cases that I will be sharing that you will get a good idea about what we can do now with all these things in a completely broken vertebra. But yeah, it was a contraindication. I would say now it's almost a relative contraindication, or if you only have just a little bit of extension into the epidural space. You can't be doing it in like a Bilski 1C or a 2 or a 3, of course, you can't do it. But if you have just a little bit of extension with a broken posterior cortex, definitely it is doable in such cases now. Okay, so yeah, so this is a patient with melanoma as well as lung cancer, and if I'm not mistaken, this met on biopsy was a lung cancer and was not melanoma. So here again, you can see that there is destruction of the posterior cortex. The superior end plate is completely destroyed here. So I went in and I just did a kyphoplasty initially. And patient did quite well from pain perspective. His pain score came down because you can see cement is nicely within the vertebral body, no extrat, didn't come up to the back end. So it was quite good, but this is like 3 or 4 months later. This is the same patient and had retropulsion and of course ended up having decompressive surgery, laminectomy at that site. So this is what, October of 17. January of 18, the same patient now develops 2 new metastases. One is right here and one is right here. This time the patient straight up refuses to go for surgery. And so the patient so he did have some relief after I had intervened. So he said that he wants to try the same route again. So I ended up going back in, but this time I ablated this first before just dumping in cement in the vertebra. So, and this is 118 that we intervened on him, and this is a scan 10 months later, 11:30. There is no retropulsion of the posterior cortex more than what it was before our intervention. And this we just scanned him a couple of months ago. This is like almost 26 months later now. And you can see that it's exactly what it was initially. So I really think in cases such as this, where there is a little bit of retropulsion, and if you want to go interventional route for whatever reasons, whether be it just like this, where the patient refused surgery up front, I think that really we should be doing ablations, creating a cavity by ablation rather than dumping cement in a bone that has such retropulsed posterior cortex.
Majid, I have a question for you. You know, with regards to that technique, you know, is there a specific time point when you see radiographic response from the ablation?
So usually in our studies that we did, I have scanned our patients at 4 weeks, and then if they haven't gotten, because most of them are cancer patients, so they have their scans at a particular interval by their oncologist. But if they are not, I do them at 4 weeks, and then sometimes even I have done at 12 weeks, and then at 6 months at least, from my perspective. But if they are getting their scans from oncology side, then I just follow up with those scans.
Yeah. And you'll see some evidence of some treatment response at the 4-week mark.
At least I get an idea about my if I had an ablation zone of say 2.5 by 2.5 centimeter, I get a good idea at that time point whether I did achieve that or not. Was there under ablation or over ablation? And I'll allude to that also in a little bit.
Okay.
When we get to the ablation part. Yeah, and actually we are looking at our data now with ablation only cases where patient did not get subsequent radiation in those treated vertebrae, and we are looking at the appearance of those vertebrae 2 years, patients who have survived 2 years, almost 2 years is our time point, and we are seeing that what is the local regional control with ablation. So hopefully we should have that out in the next 4 to 6 months. So that brings us to the ablation portion, and so you can do a thermal-based ablation and you can do ice-based ablation. So the thermal-based really is used to be radiofrequency ablation, and of course cryoablation would be on the ice-based side. But now, last I would say about 4 or 5 years, we have another modality that has come in is a microwave ablation, and there are certain others that are coming up like lasers and all that. But basically right now, these are the 3 main types of ablations that are being done, especially in the bone world per se. So the overall reduced morbidity, mortality, lower procedural cost, we are always doing it under image guidance, whether this be fluoroscopy or this be CT. So we know that we are well within the tumor as we are treating the tumors. Most of these are done outpatient. I try to do some of my ablations under conscious sedation. But I would say that we end up most of the time, 7 out of 10 times, we end up using general anesthesia because the patient does feel the heat, and so we are really moving that towards general anesthesia only. One of the questions that I get from patients in my clinic every time we talk about this is that, okay, is surgery taken off my list for future treatments, or is there radiation out or anything out? So that we tell them that everything stays on the plate, and you can have surgery, you can have radiation pre, post, whatever. So this type of treatment modality does not take anything out of the treatment armamentarium that would be available to the patient. What are really the indications of doing ablations? So this is, and we're talking just about the pathological fractures here. So ongoing compression, persistent pain post radiation, whether this is conventional or SBRT. One thing I'll add here is that I do not do ablations for diffusely metastatic disease. I only do that for oligometastatic disease. And if I am doing a case with diffusely metastatic disease and I use ablation, that will be probably just because there is a little bit of retropulsion of the posterior cortex. Otherwise, in a diffusely metastatic disease, you shouldn't be doing any ablation because really the priority is just pain palliation. You don't want a local regional control of the disease as such. Radio-resistant tumors, of course, RCC, chondrosorts, and melanomas. Patients have reached maximal dose of radiation and they're still complaining of pain. I've had patients who have upfront refused radiation therapy because they have had radiation previously and didn't have a good experience with radiation. So they want some other modality rather than radiation. And of course, when you have the marrow-suppressions and all with the other treatment modalities that are used. This is a patient that had urothelial cancer, again, a solitary T11 metastasis, significant back pain, 12 out of 10 I put in there. And you can see this is a hemangioma that is at the higher level because this is right on T1 and T2. So that's a hemangioma. This is the solitary metastasis in the vertebra, and you can see almost whole of the vertebra is involved. There is extension through that lateral cortex here. I just want to bring your attention to one thing here, is that what you are seeing here is really what looks like the tumor edge, as you can see here on the post-contrasted image is the tumor edge. But really, the tumor, you can see some changes in the bone that are extending beyond the edges of the tumor. And that's something that I have learned from my radiation oncology colleagues. And of course, all of us know when they do their treatment planning, they have the gross tumor volume and the clinical tumor volume. And that's what I try to do when I go in for these oligometastatic disease. I try to be more aggressive and want to ablate beyond the margins of what I'm seeing. So for a case such as this, instead of just going from the ipsilateral side and ablating it, I went in and I went bipedicular approach and ablated it from, both sides, and then put cement in. And if you look under fluoroscopy, it looks really great. The cement is right in that hole, looks pretty good. So we have a hybrid system where you have the CT and fluoroscopy that you can use on the same table. You just move the fluoroscopy away and you get the CT in. And when we did that, the position of the cement post-ablation was really suboptimal. As you can see that this whole posterior aspect was not filled, although it looked really good on fluoroscopy. And again, you can see that there is, yes, cement on here, but there's a big gaping hole on the back end. So we did it under CT guidance now, and you can see that this is what it was post fluoroscopy, and this is what it was post CT, completely filled up that hole with cement by use of this hybrid system. So that's a really good thing to use if you have availability of this system. And this is the post, this is John, answer to your question. So this is a 12-week follow-up MRI that I usually try to get in these patients. This gives me a good idea about the granulation tissue, how it has formed, what ablation zone I have picked up to ablate the tumor size. So that gives me a fairly good idea about that. And this patient, I guess, had a bone scan, and there was really no activity there, which is really not that reliable. So when we go in, as I said, these are patients with stage 4 disease. Pain palliation should be the #1 goal for these patients. Yes, with oligometastatic disease, now we are thinking more and more in terms of local regional control. And one thing in people who really want to do this, you have to make sure that you have a way of putting in cement after you have ablated, especially in a weight-bearing bone. Because if you do not put cement in, data has shown that that vertebra will collapse within 3 months. So no matter how you plan it, if you have destruction of the posterior cortex and all that, and you think that you will not be able to put cement in, don't ablate, because you'll cause more problems than really help the patient based off of that. So cement, the goal has to be ablation and cementation, not just ablation only. In a non-weight bearing bone, yes, you can just ablate and you're good to go. But in a weight bearing bone, absolutely, you need to have cement on the back end. As I said, I use microwave ablation. I just wanted to give an idea what exactly this is. So this is actually electromagnetic way of inducing tumor destruction. There is no electric circuit. How it causes is that it flips the hydrogen atom or the water molecule 2 to 5 billion times per second, and that causes frictional heat, and that frictional heat causes coagulative necrosis of the tumor. I did not put the slide because I thought that we would not have that much time about why I prefer this over radiofrequency ablation. The main reason for that is, if you're using radiofrequency ablation, is that for osteoblastic metastasis, that's not a good choice because the bone impedance stops the machine, and you have to restart the machine, and sometimes you just have to give it up also. I don't have that issue with microwave ablation because, and with the other modalities, I had to actually look at a CT or an MR to see whether this was osteoblastic or osteolytic metastasis, then pick up my modality of treatment. With microwave ablation, I have the luxury of going in both blastic as well as lytic metastasis. One of the side effects, I would say, or where you have to really be very careful with microwave is that the tumor profile, the heat profile goes up very fast, very easily. And so we do use thermocouplers, especially in cases where I have a break in the posterior cortex. I put a thermocoupler within the epidural space as I'm ablating. And we know that thermal injury to the neural structures happens around 35 to 40 degrees centigrade. So we keep monitoring what's the temperature within the epidural spaces. We have used hydrodissection. So in areas where I'm very close to the posterior cortex, I have actually put in saline within the epidural space so that I get a little more distance between the ablation zone and the spinal cord. And if I'm doing it under general anesthesia, then of course I use SSEPs and MEPs for that. So just a splattering of some other cases. So this is a patient with myeloma, very resistant myeloma. Patient has had almost everything done. Had myeloma therapy, had a bone marrow transplant done, SBRT was done, had significant pain 4 weeks after radiation, and very limited ambulation with the use of a walker now. And this is the scan on this patient, and this is, Wendy, when you asked that question, that break of the posterior cortex, is that a contraindication? So as I said, that used to be contraindication. Here you can see that there's really no cortex left. There's destruction of anterior lateral posterior cortex, and you can see this is the PET scan on this patient. So how would you proceed to treat this patient? Because pretty much radiation is out here because the patient has already had SBRT and is still complaining of pain. I guess John, or if somebody else wants to say vertebrectomy, probably, you think would be a good one for this?
Yeah, I think this is tough because, like you said, I mean, I think we tend to, I mean, no, I don't want to overgeneralize, but I think we tend to think that myeloma is so radiosensitive and sensitive to systemic therapy. But you know what? If this patient's already been through so much in bone marrow transplant, that means that they're probably not going to respond to a lot more. In addition, I think radiating an already weakened vertebrae is not going to really help that mechanical aspect of the pain. I think that's something you covered very well before. I think this is tough. I mean, I think it's also the morphology of that L5 vertebral body. It's so flat in the middle. You know, I don't know, even if you fill the entire cavity with cement, I don't know how much sort of load-bearing capacity that's going to that's going to help that patient out. I mean, but then again, a anterior column reconstruction surgically here is also not trivial, you know, either through a anterior or lateral approach. It's not trivial, especially with the poor bone quality that you can see there on the CT scan. So I'm curious if you have some innovative.
Yeah, I'm glad you said that, and that's exactly what when we discussed this was exactly what was discussed in the tumor board. That okay, radiation is out, surgery doesn't look like a real good option for this patient.
Yeah.
So it was punted on to me that can you do anything? I said okay, I'll try, and so we took us 2 sittings. We ablated this and then put cement in this, and this is what it looked like. And this is what it looked like post ablation and cementation. So there was no retropulsion. We filled up the whole vertebra, almost gave him a vertebra of cement. And this was the PET before, and this is the PET after our treatment. And the patient did actually very well, and he's walking with the use of a stick, where he was almost not ambulating at all.
No, that's great. That's a great result. And I think that part of the challenge here too is I think that, I think people get used to this sense of, oh, there's like mechanical pain, that's a surgical problem, and it's not necessarily the case, I think, with a lot of the techniques that you're showing. And I think especially in that intermediate zone where there are some equipoise there, I think there are a lot of considerations too. I mean, if you have access to someone as skilled as you that can do something like that, I think that's really great. Otherwise, I mean, we're talking about, front, back, type of surgery.
Yeah.
There are a lot of people on the chat board saying, that's what they would do. And yeah, I mean, as surgeons, I mean, we can do all that, but I think that it's, I think if, it's just like, it all comes down to what is going to make that difference to the patient, right? And so if you can do that with relatively low morbidity, I think that's a great option.
Yeah, thank you. So this is another case, just a couple of cases I want to show, and then I'll wrap up. This is intriguing me a lot now. I'm seeing this more and more. So this is a T10 metastasis. We went in, we ablated, we put the cement. This was really no extrav. They had a little bit of epidural component, but the patient did quite well. This is the 12-month follow-up MR and CT. The bone did collapse, but you can see the cement is nicely in there. There's no retropulsion now. And but what is intriguing here, if you note, is that what has happened to the bone here. Let me show you right here. This is what it looked like, and the patient did not have RT. So I honestly don't know what is the ablation causing this, because this is something that I have noticed now on few of my patients who have not had RT, but we just did ablations. And I have seen this change in the bone quality or the bone density in some of these patients also. This is something that is really intriguing to me, but hopefully we'll get an answer someday what really is causing.
Majid, are you talking about the other levels looking more osteoporotic now? Is that what you're?
No, even this level, because normally you would expect this post radiation that you would get from a lytic bone, you would get it completely, the density, even the posterior elements. That's the surprising part.
Increased density.
Yeah.
Because I was going to say your other bones look less dense now on this CT compared to your pre.
Yeah, probably.
Yeah.
But no, I'm talking about this. Why am I getting even more density back here? I really don't have an answer to that. But as I said, I have seen that in quite a few of my patients now. This is another case, similar, complete bone destruction. This was also one of the patients who had to go to SBRT, couldn't lay on the table. And this is the one that we ablated, and then we used up our straight balloons, curved balloons, and filled those holes up without any extrav of the cement. And that's just to drive the point that we do have things now that we can use protective mechanisms that really help us to keep the cement in place. And plus, cements have also gotten much better. They're much more viscous than they used to be previously. And as you can see that pre and post, it looked quite nice. I know this is not a spine case, but I just wanted to end off with this case because I think this is perhaps one of my best cases. And I just wanted to share it with you guys. So this is a 24-year-old male with an acetabular lesion. He was in the Army, severe pain. Being in the Army, very high pain threshold. He tried everything under the sun to help him with his pain. Nothing really helped him, and he was let go from the Army. And that's when he came to our hospital, my previous hospital, not at Hopkins. And when he came, he was using a walker to assist in his ambulation, and a 24-year-old guy. So this was a CT, and you can see that there's a big, huge gaping hole in his acetabulum, supraacetabular region. The femoral head is like floating because there is no acetabular cover over the femoral head. So the ortho-oncologist, I don't know, I bet there are some orthopedic surgeons on here also. I would love to have their comments, what they would do in a case such as this. But the ortho-oncologist at our institute that time, they said that it has to be more of a radical surgery than anything minimally invasive, because there's really no acetabulum cover there. And the patient obviously refused. He said that, is there anything that can be done? And that's when I get a call from my oncologist, ortho-oncologist, that can you do anything? I said, yeah, this is like a big, huge gaping hole. And if you don't do any big surgery right now, by the time I'm done and my cement leaks into the joint space, you will have to do a complete hip arthroplasty or something. Said, yeah, that we can take that chance because that's the only option left for this patient. So that's why I'm interested in the group, if they have any expertise in this, to know what they would have done in this case, because I biopsied it and this turned out to be a giant cell tumor of the bone. So I did some lit search, and there were these two papers from, I guess, probably from South Korea that had come out, and that said the Zoledronic acid, which is a bisphosphonate, remains active in the bone cement, and it actually eludes out of the bone cement for about 15 to 20 days. So that really got me intrigued because it's a osteoplastic inhibitor, and I said this is a GCT after all, and so if you can decrease the osteoplastic activity, I said maybe I could get a little bit of bone formation that can help me put some cement in there. So I went in, I just ablated it just to stir up the tumor, and I just instilled straight out Zometa intralesionally within this acetabular hole. And I told the patient to come back within a month. This is a scan that we obtained a month later, and lo and behold, I did see some calcification / ossification that had formed at that level. That gave me some hope. I didn't do anything this time. I said, okay, come back in a month and we'll see you in a month. And this is a month later, and you can see that more ossification / calcification has formed. There's even some calcification in the iliopsoas muscle that had formed in the interim there. So this time I went in, I mixed, which is not FDA approved, I mixed Zoledronic acid with bone cement. I got a working time of about, I think about like 35 minutes when I mixed it with this, because I actually started putting the cement in at about 15 minutes because it was like liquid when I mixed the cement and this. So I did him like at least 2-3 times, I think 4 times actually I did. And this is what it looked like when I started, and this is when I got done with him, this is how it looked like. So we really gave him an acetabulum of cement, but I draw your attention to these areas. These are actual bone that has formed. Again, as I said, I really don't know what this is, but I am seeing this frequently, not frequently, but I'm seeing this in my patients. And this is the guy.
Basically, I'm running 2 miles every other day. Ran 3 miles most. I'm deadlifting, doing heavy weights, working out 6 days a week. So
that's really awesome.
So this is a guy who was using a walker for ambulation, and he's enlisted back in the Army. So I thought this was a really good achievement. So in summary, I would say that a multidisciplinary approach is the best way forward for these spine oncology patients, just like anywhere else, brain tumor world, ENT world. Triaging patients based on everybody sitting on a table and deciding what is the best way to move forward treatment-wise for a patient makes a lot of sense, rather than sending out these gazillion emails from radonc to neurosurgery, orthopedic surgery, interventional radiology, that, okay, who's going to do what, and you just get lost in that. So really setting up a multidisciplinary tumor board is probably the best way to move forward, especially if you're treating a whole lot of these patients. And I think everyone has a role to play, and we in interventional radiology are just little kids on the block, but I think we do have to offer some help, especially in that 7 to 12 SIN score range. Thank you very much. And again, thank you for giving me an opportunity to talk with this lead group. If there are any questions, I'll be more than happy to take them.
Thanks so much, Majid. That was fantastic. And I think most people here didn't know like all the options that are available now, and a lot of them from radiology. All this is very new. So now people can go back and tell their partners and know these are options in their own practices.
Absolutely. That exactly was my intention. That I know, because talking in all these national meetings and all that, I have people come up to me and say that, oh, really? You can do this? I had no idea. And as I said, hopefully if I get to talk on this forum again, I will share all the data and give a talk just based on ablation, because as I said, this has made it to the paradigm of spinal metastatic disease treatment.
That's fantastic. John Shin is still not muted. So John, do you have any last comments here?
No, I think that was really excellent, and I'll admit, I mean, for those of us who sort of play in this sandbox quite often, there's still a bit of a knowledge gap, you know, with all these different interventions, you know. So I think that the more, and I think that speaks to having the tumor board at your institution, because then everyone, whether you're a radiation oncologist or, you know, interventional radiologist, surgeon, you're kind of using the same terms and speaking the same language, you know, whether
Absolutely.
it's thins or whatever. And, you know, just like hearing you talk about ablation and the different technologies and curved balloons. I mean, and the other thing I also noticed too is that your cement placement, it definitely looks a lot more professional than what we do when we do it in the operating room. Because I'll tell you, I put cement into the body, and just like Shuba, I put cement through the screws, and it's hard for us to control where that goes. And maybe we're just impatient as surgeons, you know, but I always find that when I see you and give your talk and other colleagues like Eric Liss, I mean, the cement fills are just really packed in there with very little extra. So I think there's a lot to learn, and I think it's really great. Thanks for sharing your time and expertise.
Oh, thank you. Thank you.
Jonathan Razzulli, are there any other questions that we didn't address in the chat?
Dr. Khan, I was just wondering, that was a great presentation, by the way. Do you have any experience with the Spine Jack by any chance? It's a new Stryker product that came out.
Yes,
is this, I guess, kind of next?
Yeah, I've done close to about 100 cases now with Spine Jack, but first up, it is not FDA approved for cancer. It is only FDA approved for osteoporotic fractures. I did have a talk with our neurosurgery colleagues here and orthopedic colleagues that should I use the Spine Jack first up, I only use in patients with moderate to severe compression fractures. There is no use of Spine Jack use in mildly compressed vertebral bodies, because the real use of Spine Jack is to restore vertebral height. So that's the question I pose to our surgeons here, that if I do that, would that hinder treatment? Because some of these patients do end up going to surgery later on, and would that hinder? And Dan Schuber really said that it won't hinder me a whole lot, because we can cut through the titanium and all that, but at least I need to know beforehand that if you're going to place that. So this is something that we don't know a whole lot. I have put them in myelomas, definitely, because myelomas, as we already alluded to, are mostly managed conservatively with radiation as well as conservative treatment. So I have put in myelomas, but I have not ventured into the metastatic world yet with Spine Jack.